Our friend from Brazil, Marco Túlio Rezende, who will talk about anterior cranial base, DAVFs, and the vascular treatment as a first-line approach.
From Russia. My name is Marco Túlio Rezende from Belo Horizonte, Brazil. I would like to thank the organizing committee for the invitation, especially to Professor Kiri Orloff. Duroarteriovenous fistulas of the anterior coronal base, also called ethmoidal fistulas or cribriform plate fistulas, are extremely uncommon lesions. These fistulas are unique because they always have retrograde leptomeningeal venous drainage and are mostly supplied by feeders from the ethmoidal branch of the ophthalmic artery. The risk of inadvertent occlusion of the central retinal artery makes transarterial embolization problematic. On the other hand, transvenous embolization can be extremely difficult because of the typical exaggerated tortuosity of the draining veins. So, anterior cranial fossa dural arteriovenous fistulas have been almost exclusively considered as surgical lesions. Surgery is performed in a non-eloquent area of the brain, allowing wide exposure of the fistula, which is typically easy to occlude and enabling associated hematomas to be removed simultaneously. The success rate of surgical treatment is between 85 and 95%, so it's high, with a complication rate which is considered acceptable, varying between 5 to 90%. This meta-analysis included 5 studies comparing surgery to endovascular treatment. All were retrospective observational cohort analysis. In total, 81 patients were included, and complete obliteration was obtained in 100% of the patients after surgery, compared with only 47% of the patients after embolization. However, surgery exposes the patient to the risk of a craniotomy, of course, including blood loss, infection, and postoperative hemorrhage, also more discomfort than endovascular treatment. Moreover, surgical access to the anterior cranial fossa may put the olfactory nerve at risk, and a postoperative cerebrospinal fluid fistula can occur. So, why not to understand better the results of the endovascular treatment? Some studies have described very, very low occlusion rates after the endovascular treatment. Lawton reported the injection of PVA particles through the internal maxillary artery in 3 patients. All patients were subsequently referred to surgery. So PVAs do not produce a durable cure and should only be used as a palliative management. Gross reported an overall endovascular occlusion of 22%. So even with the use of embolic liquid agents. So only one transarterial embolization resulted in a complete occlusion of the fistulas. This series involves 8 patients. So in our opinion, failure could be explained by the fact that onyx or glue or any other liquid agent did not reach the proximal portion of the draining vein. On the other hand, most recent studies have reported higher occlusion rates after endovascular treatment. Dabus reported a multi-center experience in 2021, using endovascular therapy as a first-line approach in 23 patients. The overall immediate complete angiographic cure was 82%, and the cure rate with the transvenous approach was significantly superior to that with the transarterial strategy. So this was the most important series published just to 2021. So recently, we conducted this multicentric study of patients harboring anterior cranial base durofistulas who had undergone endovascular treatment as a first-line approach. So between 2008 and 2020, 37 patients with ethmoidal durofistulas were admitted to the participating centers, 2 from Brazil, including ours, and 2 from France. In 2 patients, endovascular treatment was not attempted. In 1 patient, spontaneous thrombosis of the fistula was observed on the day of the treatment. So, of course, this patient was not submitted to endovascular treatment. In another patient, endovascular access was judged to be impossible because of a very tortuous ophthalmic artery with a long cortical draining vein. Thus, the patient underwent microsurgical obliteration of the fistula. Finally, 35 patients underwent endovascular treatment as a first-line procedure. Remember that this pathology is a very hard disease. So the mean patient age was 58 years old, and 54% of the patients were men. Almost 50% of the cases were asymptomatic, and the most frequent clinical presentation was related to intracranial hemorrhage. The ophthalmic artery was involved in all cases. The second most feeding artery was the internal maxillary artery, followed by the middle meningeal artery. So the ophthalmic artery supplies all fistulas. 22 fistulas received bilateral supply, and most lesions were supplied by multiple feeders, including the ophthalmic artery. Transactive approach using the largest ethmoidal branch was our first choice, different from the recent series published by Dabus. And one example, an ethmoidal fistula, a classic case, supplied exclusively by the ophthalmic artery, draining to a dilated and tortuous frontal basal vein without connection to the superior sagittal sinus. So some tips and tricks about the ophthalmic artery catheterization. So the lateral projection is always the best working angle to visualize the origin of the ophthalmic artery. We recommend the use of distal access catheter to provide optimal support for microcatheter navigation. Remember that the central retinal artery originates from the second segment of the ophthalmic artery, so it's mandatory to position the microcatheter tip distal to this segment. And DMSO compatible microcatheter without detachable tip is preferred because of better navigability. A wedged position of the microcatheter is desired because it will reduce the risk of reflux, and a security zone to allow reflux must be present as reflux always occur. So EVO 18 final cast that determined the total obliteration of the fistula and preservation of the ocular supply, as you can see. Same situation, fistula supplied exclusively by the ethmoidal branch with a very, very tortuous and dilated drainage vein. Distal access catheter and the microcatheter tip placed in a safe position far away from the second segment of the ophthalmic artery. Observe that the liquid agent filled the proximal part of the drainage vein, and this is really crucial to determine the permanent occlusion of these lesions. Final control showing that the fistula was occluded and the corollary supply preserved. To obtain successful ophthalmic artery access, another important tool is the balloon. So we need to understand how to use a balloon-assisted technique to catheterize the ophthalmic artery when necessary. So an ethmoidal dural fistula supplied exclusively by the ophthalmic artery, draining posteriorly to the basal vein of Rosenthal. So it's a challenge case to be accessed by the venous side by obvious reasons. So as I showed, the ophthalmic artery catheterization can usually be performed with a microcatheter and a microguide wire. However, in some cases, it's necessary to navigate the microcatheter beyond the origin of ophthalmic artery, as in this image. Then the microguide wire is withdrawn from the extremity of the microcatheter, which is slowly pulled back just to the origin of the ophthalmic artery. After that, a microguide wire can be advanced, followed by the advancement of the microcatheter. Okay, if it works, okay, nice, let's continue, but it's not uncommon for the microcatheter to be kicked back when the microguide wire is advanced. So what you do, so in this scenario, use a balloon inflated distally to the origin of the artery to prevent the prolapse of the microcatheter and to give support for the navigation. Now it's okay. So it's really important to recognize that in some circumstances, we will need to use the balloon-assisted technique to catheterize the ophthalmic artery. Another case, an anterior cranial base dural fistula draining to the superior sagittal sinus by the frontal-basal vein. The lesion was supplied by the ophthalmic artery, middle meningeal artery, and internal maxillary artery. Late phase angiogram shows a venous aneurysm and a long, very long draining vein. As was said, we prefer to use a transarterial approach as our first alternative. So a microcatheter was placed in the ophthalmic artery, but its tip was very, very close to the origin of the central retinal artery. So the position, in our opinion, was not safe to inject any liquid embolic agent. That's why we decided to use the middle meningeal artery as an arterial access to inject onyx, observe the tip of the microcatheter into the anterior falx artery, and the onyx filling the draining vein as we consider the best way to occlude these fistulas in a permanent fashion. So the final control angiogram revealing the total occlusion of the fistula. Note that the central retinal artery and the blush of the choroid were preserved. In our series, an isolated transarterial approach was performed in 54% of the cases. Obviously, some patients were treated by transvenous or combined access. The ophthalmic artery was the most accessed vessel, and excessive reflux occurred in one patient, and determining one clinical complication I'll show you at the end of this presentation. And the second most accessed artery was the middle meningeal artery, as shown at the last case that I presented. Talking about the venous drainage, the most common venous drainage was to the frontal basal vein, to the superior sagittal sinus. So almost 70% of the cases harbor this type of configuration of venous drainage, but other routes were found as basal vein horizontal, labe vein, cavernous sinus, or the superficial middle cerebral vein, and also some mixed patterns as superior sagittal sinus plus superficial middle cerebral vein, or superior sagittal sinus and basal vein or horizontal. Venous access was used in some situations as a second option, in very tortuous and thin ophthalmic artery, in patients who were already blind in the contralateral eye, in case of non-total occlusion after transarterial approach, and after failed catheterization of the ophthalmic artery. So a ruptured ethmoidal fistula draining to the superior sagittal sinus via frontal basal vein with a very tortuous carotid siphon and curved ophthalmic artery origin. So we decided to go by the venous side, embolization with Caius and onyx, with total obliteration of the fistula, as you can see before and after the procedure. Total angiographic occlusion was achieved in 91% of the cases whose treatment had been accomplished. 6-month control angiography revealed that 88% of the fistulas were totally occluded. One angiographic recurrence of a fistula that had been judged to be totally occluded on early angiography was later observed. So that's why we need to be sure that the foot of the vein was totally occluded. And after 6 months control, 4 patients, including the recurrence, were referred for surgical treatment due to partial occlusion. So an ethmoidal fistula supplied by the ophthalmic artery and the anterior cerebral artery. Supercellative angiographic image through the microcatheter placed inside the ophthalmic artery showing the fistula zone and the foot of the draining vein. This is our target. And the dilated and tortuous trajectory of the draining vein. That's why we decided to go by the transactive approach. Why? To use transvenous approach in this circumstance. It's not possible. So the final onyx cast, feeling the foot of the brain. This feeling is crucial to determine definitive angiographic obliteration of these lesions. Note that the blush of the choroid was preserved. So the reported complication rates in the literature varies between 0 and 16% of the cases. Our complications occurred in 3 patients, 80% of complication rates. Central retinal arterial occlusion due to onyx reflux during transarterial approach via the ophthalmic artery was observed in 1 case. Venous perforation occurred in another case, and the patient presented with palinopsia postoperatively. And finally, monocclusion of an M2 branch of the middle cerebral artery was observed during a transarterial approach to the fistula, and thrombectomy was performed to achieve total recanalization. So concluding, most anterior cranial-based dural fistulas can be successfully treated by an endovascular approach. The choice between transarterial and transvenous approach depends exclusively on the anatomy of the fistula, as I showed you. And the result seems to be equivalent regarding the occlusion rates and complications in our experience. Neurological and visual complications are rare, even if the ophthalmic artery is used as a primary access route. And of course, that E4 should be directed to compare the results of endovascular treatment and surgical managed by prospective studies. Thank you so much for the opportunity and have a nice day. Bye-bye.